Thank you everyone for coming. My name is Dr. Nishant Patel. I work here at Palm Beach Gardens Medical Center, which is part of the Palm Beach Health Network. I practice cardiac surgery here. As Teresa mentioned, I've been here for a handful of years now. And my story with the patient who has given me permission to use his name and discuss his medical history began last Tuesday. So I just completed a couple of routine cardiac operations, and around 2 o'clock in the afternoon received a phone call from one of my colleagues over at St. Mary's Medical Center, just down the street from us here at Gardens. And basically the ER physician told me that they had a patient who had passed out on an airplane, and after passing out on an airplane was sent to St. Mary's Medical Center for concerns of stroke. He had left-sided facial droop or weakness. He wasn't moving one side of his body. He seemed to be neglecting one side of his entire visual field. And so he had an appropriate workup there for a stroke, which was a CT scan, and the lower parts of the CT scan, which include the neck and the upper part of the chest, demonstrated what's called an acute type A dissection, which is a cardiac surgery emergency. So at that point, we made the decision very promptly to transfer the patient from St. Mary's to Palm Beach Gardens Medical Center, which is a cardiac surgery site. Upon arriving here, I did meet the patient, Ken, in the emergency room. I spoke to one of the passengers that was actually on the airplane that made the drive over as well, and left a voicemail with his wife, who was on an airplane on the way down here from Lake Wales in Central Florida. So after seeing the patient, we rushed him off to the operating room for a repair of his type A dissection, which is a high mortality case. About 50% of patients who have this diagnosis won't even make it to the hospital. Once the patient does arrive to the hospital, every hour that goes by is a 1 to 3% chance of passing away without treatment. And even with treatment, surgical treatment that is, the risk of passing away with the operation or within the hospital stay is quite high. Many years ago, we used to quote patients that your risk of passing away was up to 50–60% with the operation, and near certainty for passing away without treatment. And over the past few years or decade or so, the outcomes have really improved to the point where we can tell patients who come to us that are otherwise in good health that their likelihood of surviving is around 15 to 30%, depending on the risk factors that they come in with. So we rushed him off to the operating room in the late afternoon of Tuesday. The operation completed close to midnight that night. He did very well. We replaced the ascending part of the aorta, which is the critical part of the procedure. And we did this with the assistance of something called circulatory arrest, where the body is no longer receiving any blood flow. But we do it with another technique called antegrade cerebral perfusion, which allows us to actually deliver oxygen and nutrients to the brain while the rest of the body is cooled down to about 20 degrees. So following the operation, thankfully, we had no issues with bleeding. Shortly after returning to the ICU, we were able to wake him up. He actually had return of all neurologic function, meaning he had no further weakness in either his facial muscles, his extremities, his visual fields were completely intact. And we were able to take the breathing tube out that following morning. The rest of his post-op recovery was actually quite smooth. He was discharged home 6 days later on Monday, just this past week. And he is resting comfortably locally and has been in touch with me and my team is doing quite well. So that's his story in a nutshell. I'm happy to take questions.
Question. I'm wondering if the pilot had like high blood pressure, some of the things that lead to this? Did he have any genetic disorders like Turner syndrome that would have been a sign of this?
So that's a great question. The risk factors for a type A dissection include genetic causes, if you're alluding to, such as connective tissue disorders, Turner syndrome. This can sometimes be sporadic, meaning it's the first time the patient or the family has an incidence of something like this, or it can actually run in families for generations, and the patient did not have any family history or any pathognomonic signs of any of those kind of conditions. He does have high blood pressure, but he's actually a very healthy individual. He sees his primary care doctor twice a year. He's on appropriate medication for high blood pressure. Type A dissections can happen when you're at rest, when you're asleep, or when you're exerting yourself. So, but no other findings that would predispose him to a type A dissection, with the exception of blood pressure, high blood pressure.
How old is Mr. Allen?
64.
Thank you.
Dr. Patel, I think you said about 50% of those that go through this don't even make it to the hospital. Just kind of detail for us how incredibly lucky this pilot is. I mean, first of all, to be on that airplane and that passenger able to land the plane, and then doing it without panicking, getting on the ground as quickly as possible. Did that also help save his life to get into the hospital as fast as he could?
I mean, the story is a miracle after a miracle, really. You know, for him to be able to survive the event, an acute type A dissection is really acute. It is hyper acute. It happens suddenly. So the moment he was describing to his friends on the plane that, hey guys, I don't feel well. I have the worst headache of my life. I'm feeling fuzzy, dizzy. That is the exact event that the tear occurred in his aorta. So to be able to survive that acute event was really quite remarkable. We know that sudden onset chest pain, advanced age, signs of malperfusion such as stroke-like symptoms portend worse outcomes. So he had all of those, survived the tear itself. The fact that his friends were able to land that plane with the assistance of air traffic control. I mean, that in and of itself was quite a miracle. And then from there, to survive the trip from the airport to St. Mary's, we promptly evaluated there, and an astute team of physicians and staff and nurses identified that he had something quite a bit more than just a stroke, and got the patient to us here at Gardens for emergency surgical care. Every step of the way was really extraordinary, that he was able to get through it with the ease that he displayed in his post-op recovery. The first thing he says to me in the morning after surgery is, "When can I go home?" And I can tell you that is not the typical question that you get the morning after a type A dissection repair.
It sounds like there were about 3 or 4 hours in between the initial event and when he made it to the operating room. Was there any sort of damage control you had to do that occurred in those 4 hours? Was the surgery made more difficult by the time that lapsed in between the incident and the surgery?
So once the diagnosis of a type A dissection is made, immediate treatment is incredibly important, and it basically centers on something called impulse control, meaning you want to have low blood pressure and low heart rate to minimize the tension that is put on the wall of that torn aorta. And so that began almost immediately. Once I got the phone call, we put the patient on a variety of medications through the IV that allow us to very finely control his blood pressure and his heart rate. And then the rest of it is really just getting the patient to the operating room with the appropriate catheters and IVs and lines, etc., that allow us to deliver the surgical care that we need. And the idea behind the urgency is to prevent what we call aortic catastrophe, right? So the aorta has 3 different walls in it: an inner, middle, and outer layer. When the tear occurs, it occurs between the inner and the middle layer, and the blood starts to create what we call a false lumen inside that wall. What we're trying to prevent are a couple of things. One is acute or frank rupture of the aorta, where the entire aorta falls apart and the patient unfortunately bleeds out, and prevent what we call malperfusion. So as blood starts to go into this false lumen through the tear, it can compromise the blood flow to the rest of the organs, namely the brain, the kidneys, the liver, and your limbs. So really impulse control to keep the heart rate, blood pressure down, and getting the patient to the operating room, which is the safest place for a patient with a type A dissection to be.
Was the patient conscious at all from the time the plane landed to the time he arrived here, or was he unconscious through the entire afternoon?
When Ken arrived to us here at Gardens, he was alert.
Okay.
He was alert and was able to converse with me, and he was appropriate as well. He was able to tell me his wife's name, her phone number. By report from St. Mary's, when he was picked up from the airport, he was still confused, lethargic, and having symptoms consistent with a stroke, which is what led to the transfer to St. Mary's.
Dr. Patel, was he having those stroke-like symptoms because was there a lack of blood going to the brain due to the tear at that moment?
That's right.
And when you perform the surgery, it sounds incredibly complex. Is it similar to open heart bypass surgery, where you actually have to stop the heart, go into the chest, and he's breathing on the ventilator?
This is quite a bit different from bypass surgery. It does require stopping the heart, like some bypass surgery requires. In addition to stopping the heart, though, Ken's procedure also involves something called hypothermic circulatory arrest, which is something you would really not do for bypass surgery or valve surgery. And what that means is you cool the patient's core temperature down to 18, 20 degrees. And you do that to preserve cells, preserve brain cells, as well as help preserve the rest of the organs in the body. And what that allows us to do is actually come off of something called the heart-lung machine, which is what is providing oxygen and nutrients to the body while you're doing routine heart surgery. So the entire blood flow to Ken's other organs are completely stopped, with the exception of the brain in this case, because we were able to perfuse the brain through a technique called antegrade cerebral perfusion, where we deliver oxygen and nutrients through the brain through the axillary artery, which lies here under your right collarbone. When you cool somebody down that low, the clock is ticking. The longer somebody is without blood flow, or even slightly less blood flow to the brain, the more chances of neurological impairment or even devastation. So it really is an operation that requires appropriate preoperative planning, timing, get the patient to the operating room as expeditiously as possible, and then both precision and speed. It's one of those rare combinations of procedures in all of surgery that requires both precision and speed.
How many times have you performed this type of surgery on someone with an aortic dissection?
Well, it comes in threes, they say. So I've done 2 this month, so I'm waiting for the third one. But it's not, I wouldn't be able to tell you how many. There are plenty.
Sounds like it's common.
It's not routine cardiac surgery. I do about 2 operations, routine cardiac surgery operations a day. Valve surgeries, bypass surgery, type A dissections are something that's never planned. If I had to guess, it's probably a dozen a year.
What's the long-term prognosis for Mr. Allen? Will he be 100% recovery, hopefully?
That's a great question. So where we've made a lot of the progress in the care of these patients are early outcomes. Right? So our operative mortality rate, the chances of a patient passing away with surgery, those outcomes have improved quite dramatically, to the point where we can safely say in otherwise healthy patients that come to us with good perfusion and good end organ function that their chances of passing away with the operation are around 15 to 30%. Still incredibly high compared to routine cardiac surgery, but much favorable compared to what the odds used to be many years ago. The long-term data suggests that about 5 years, 90% of patients will be doing just fine.
Doctor, would you be able to clear him for flying?
That wouldn't be up to me. I believe that would be up to the FAA. From my perspective, where he had his life-threatening event, that part he should be cured from.
Weird question, but him being elevated for so long, did that maybe prolong his positive status and outcome different than being on the ground? Does elevation play a certain game in this or no?
Not to my knowledge, and you know, this is the only story like this I've ever heard of. So there's not much data to go by. I think if anything, being elevated only put him, you know, at risk because of the potential for delay in care. You know, at any point in this story, he could have had a frank rupture of his aorta, which would have been likely life-ending.
Are there any warning signs of this type of situation, and did he have any previous symptoms?
So, type A dissections, acute type A dissections, which can happen suddenly. It's a hyperacute process. The moment he started having symptoms is the exact moment that he tore his aorta. So really the prevention for this is, really good type blood pressure control, avoiding smoking, good balance in terms of diet and exercise. And then of course, if there is a role for prevention, it's really patients that have a family history of either aortic aneurysm or aortic dissection. If Ken was a 30-year-old male who had a father who had this and a grandfather who had this, et cetera, then this is where you would talk to Ken's children and grandchildren and say, let's get you into genetic counseling and get you hooked up with a good cardiologist and get some imaging of the chest to see if there's either an aneurysm, ultrasounds of the heart to see if there's any valvulopathies, aortic valve abnormalities can be associated with aortic aneurysm and dissection. So that's where there would be benefit for prevention. But in Ken's case, this happened really quite suddenly without any symptoms prior to the actual event.
And how stressful was it for you, Dr. Patel? I'm sure you knew the story that he had just narrowly avoided death in the air through this heroic flying of the plane, but now he's on the ground and it's in your hands to save one of the lives.
Well, I mean, this is my job, really. It's kind of strange to say this, but it is my favorite operation to do. I trained at a site that fortunately was blessed to train at a site that did a lot of aortic work, so I'm very comfortable around the aorta. So I wouldn't feel any more stress than I would with any routine cardiac operation because I've just been trained to do it.
And how do you fix the tear?
So there are many different ways, but the way that we did it for Ken is you excise the aorta that is torn. You reapproximate the layers by suturing them, usually with what I do is put a piece of felt inside the layers and suture it closed so that no blood can then go into that false lumen. And then you basically, the aorta that you've excised, you have to replace it. It's like plumbing. You cut a piece of pipe out, put a new pipe in. So instead of pipe, we used what we'll call a Dacron tube graft. So a synthetic graft that we hand stitch the proximal end, the distal end. And in his case, because we had to do it with circulatory arrest, we did a little bit more extensive work on what's called the aortic arch. The aorta is split into the ascending, the arch, which looks like an arch, and then descends down into the belly. So we did a little bit of extensive work there to excise some of the tissue that was, very torn up, and put it back together, like I said, with a felt strip and suture. Any other questions?
Anything we didn't ask that you'd like to say?
I think, cardiac surgery, especially for something like a type A dissection, is really a team sport. It is EMS week, so happy EMS week to our EMS responders who, played a very critical role in Ken's story as well, getting him expeditiously over to St. Mary's. For that team to recognize a cardiac surgery emergency, even though it's not a cardiac surgery hospital, is very astute. And then getting the patient here where I truly believe we have the best heart surgery team in the county. I'm sure everybody says that. But I truly believe we do. We do these kinds of operations all the time. And then the surgery is just one aspect of it. A lot of it is, of course, the post-operative recovery with our nursing staff, our rehab nurses, our nutritionists, dietitians, ICU team. So really it is a team sport, and it takes a village to get somebody like Ken through something quite potentially calamitous.
I saw his wife pop up on our Facebook Live. Do you want to say anything to Ken and his wife who are watching?
See you next Thursday. Ken's a really, what's lost in all this is what a great guy is. I mean, he's such a great guy. And, it's nice after 2 years of really challenges in the world and in healthcare specifically to have a save that involves so many different aspects from being in the air, being on the ground, EMS, 2 different hospitals, 2 different teams. Really nice to have quite a positive story in what's been a challenging few years.
How many in-person follow-ups do you need to do with Mr. Allen before he can go home to Liz?
Well, so he's not too far away, and he has my cell phone number, so he knows how to get to me. But I usually keep patients here for a couple of weeks before I let them travel back home. Being in South Florida, we do see patients that are on vacation that have acute cardiac surgery needs, and I usually hold on to those patients that live, say, out of state or out of country for about a month before I let them travel.
Thank you.
Thank you, Doctor. Incredible work.
Thank you.
Can I take a photo of you real quick? If you
Oh, sure.
stay.